This video is designed to offer an overview of the techniques used in applying and maintaining the PMT halo vest orthosis. It is by no means complete, and the patient's medical condition and anatomy must be considered in each case. Physicians are referred to the PMT halo manual as well as their PMT representative for additional information. Before beginning this presentation, several design features of the PMT halo deserve special attention. First, nylon ball joints are used to connect the halo bars to the ring and vest. These joints are designed to allow maximum adjustability and facilitate rapid and accurate cervical spine positioning. Secondly, the PMT halo is constructed of lightweight graphite and titanium, rendering the device CT and MRI compatible. Recent studies have documented that this combination produces the clearest MRI images. Stainless steel pins or attachments should not be used with the PMT halo. For optimal halo application, ample room and assistance are crucial. Our standard prep table is shown here. Please see the instruction manual for a detailed list of instruments. Prior to positioning the patient, ring and vest size are approximated from patient measurements. The ring size is estimated from the head circumference, measured from points 1 centimeter above the eyebrows and the pinnae. The vest size is estimated from the circumference of the patient's thorax at the level of the xiphoid process. These measurements provide rough estimates, and proper sizing is confirmed at the time of application. Standard precautions regarding cervical spine stability are taken while transferring the patient to a suitable stretcher for halo application. We prefer lifting the patient and placing him into the posterior half of the vest. Note that the posterior bars are already in place and that the base of the spoon-shaped head holder is outside the vest, thereby simplifying its removal when its function has been completed. Several methods of positioning the halo ring during its fixation to the skull are available to the physician. The ring may be held manually, or plastic-capped positioning pins may be inserted through vacant holes in the ring. Alternatively, PMT provides an outrigger which connects to the head holder. This skate assembly allows motion in all three planes and provides the most rigid positioning of the ring. Optimal ring position is symmetrically around the skull, below its greatest diameter. The ring should be free of the pinnae. Additionally, ring position dictates pin position. Anterior pins must be placed in the anterior safe zone, which is slightly superior to the lateral one-half of the eyebrow. Care must be taken to avoid the supraorbital nerve, supratrochlear nerve, temporal artery, and temporalis muscle. Pins through the temporalis muscle are anchored in relatively thin bone and will cause pain during mastication. Posteriorly, the pins are placed in the relatively thick occipital bones. After shaving the hair, and with the ring held in proper position, the skin beneath the appropriate holes is anesthetized with 1% lidocaine and epinephrine in the usual sterile fashion. Pins are inserted using 2 torque screwdrivers. The wrenches are initially set to 2-inch pounds, and diagonally opposite pins are tightened simultaneously. When the wrenches click, they are increased to 4-inch pounds, and the other set of diagonally opposite pins are tightened. When the wrenches click again, they are increased to 6-inch pounds, and the process is repeated until all pins are torqued to either 6 or 8-inch pounds. Care should be taken to hold the eyelids closed while tightening the anterior pins. Failure to do so may result in binding the eyelids open. Finally, locking nuts are placed over the pins. With the ring fixed to the skull, the outrigger is removed and the head blocks are attached to the ring, utilizing the 2 lateral holes on the ring. Correct orientation is ensured by keeping the lateral holes at the base of the head block. When properly attached, the head block should form a T above the patient's head. The anterior portion of the vest is connected at the sides and over the shoulders to the posterior shell, engaging the interconnecting tabs. The vest should be pulled snugly around the waist and over the shoulders. The anterior shell is different from the posterior shell in that it possesses a breakaway seam or cardiac crease for CPR at the xiphoid line. All of the nylon balls on the vest and head holders are loosened. The posterior bars are slid cephalad through the head holder, and the anterior bars are slid caudad from the head blocks through the vest. Bars should not extend below the edges of the vest anteriorly. With all the nylon balls loose, the degree of flexion and extension, rotation and translation of the cervical spine may be adjusted. Following positioning dictated by the nature of the patient's injury, all the superstructure attachment points are tightened with the torque wrenches.
For this, the larger bit is placed in the wrench and it is set to 30 inch-pounds.
Research has shown this torque setting to yield the maximum degree of patient safety. X-rays should always be obtained at the end of halo application to confirm the position of the cervical spine. The patient should be reassured that the initial pain and pressure will gradually resolve over the first 24 to 48 hours. Within 48 hours post-halo application, both skull pins and superstructure attachment points should be routinely retorqued to their initial setting to help prevent complications. Remember to loosen the locking nut prior to retorquing the pins. No other routine torquing of halo pins is required. Routine pin care consists of gentle cleansing of the pin site with half-strength hydrogen peroxide daily. Betadine ointments are not recommended. The most common complications encountered are pin loosening, pin infection, and skin breakdown. Patients with loose pins will often present with complaints of increased pin pain or a sensation of movement at the pin sites. Treatment consists of retorquing of the offending pin and all superstructure attachment points to their initial settings. For infected pins, retorquing is combined with a 5-day course of PO antibiotics and results in a 90% pin salvage rate. Uncontrolled cellulitis, despite antibiotics and retorquing, usually clears when the pin site is changed, but cases of subdural abscess have been reported, so these patients should be observed in the hospital. If a pin fails to gain purchase during its insertion or retorquing, it should be switched to an alternate site, and again, the patient should be observed for 24 to 48 hours. The natural sheepskin liners provided with the PMT halo orthosis provide excellent protection from skin breakdown and are easily exchangeable when soiled. Insensate and particularly thin patients benefit from additional padding around anterior and posterior bony prominences. Patients often experience muscle wasting while in the halo and may require tightening or even exchange of their vest to a smaller size. In summary, proper application of the PMT halo vest orthosis will provide rigid immobilization of the cervical spine while allowing maximal patient comfort and minimizing complications. If you have any further questions regarding the PMT halo, you are referred to the PMT instruction manual or to your local PMT representative.